Canine atopic dermatitis was first defined as a clinical dermatitis hypersensitivity, referring to an inherited tendency to produce immunoglobulin E, IgE, in response to small amount of common environmental proteins or allergen in this case. Nowadays, it is considered more than a type 1 hypersensitivity response to environmental allergens and instead a multifactorial and complex inflammatory process, sometimes associated with an observable allergic mechanism. It's increasingly clear that canine atopic dermatitis is a clinical syndrome and not a single disease, where the skin is a main entry for allergens and that the various mechanisms that triggers may include food and isn't limited to specific IgE presence anymore. So the commonly believed pathogenesis is based on an altered skin barrier function, allowing contact between allergens and the skin immune system. The abnormal immune response, orchestrated predominantly by keratinocytes, is responsible for the different clinical signs of the syndrome. Our understanding of canine atopic dermatitis has greatly advanced over the years, but more work is needed to understand all the variation of this complex syndrome. Canine atopic dermatitis is one of the most common inflammatory skin diseases in dogs, with a prevalence of up to 20% of pruritic skin diseases and between 1 and 5 of all diseases seen in veterinary clinics. Cutaneous adverse food reactions represent 1 to 2% of skin diseases and are present in about 9 to 50% of dogs diagnosed with canine atopic dermatitis, although it varies depending upon which diagnosis is made. Many research articles suggest that several breeds are predisposed to canine atopic dermatitis. It has also been demonstrated that lesion location vary markedly depending on predisposed breeds. In some countries, higher relative risks have been described in boxers, bull terrier, French bulldog terrier, German shepherd dogs, retrievers, Shar-Pei, West Highland white terrier, and so on. In addition to breed, lifestyle is also a criteria of Favreau in his set of criteria for diagnosing canine atopic dermatitis, as dogs living in apartments seem to be more prone to develop house dust mite reaction than those that live in houses or mostly kept outdoors. The main age onset of canine atopic dermatitis is about 2 years old, between 3-6 months and 3 years old. But publications show a correlation between age and breed. For example, it seems that French Bulldog and Shar-Peis are affected earlier than other breeds, with 55 to 66% of French Bulldog and Shar-Pei affected during their first year of life, comparing with 28% in other breeds. Canine atopic dermatitis is a clinical syndrome defined by a general clinical phenotype, but also widely influenced by numerous factors such as genetics and the environment. This clinically variable and non-pathognomonic pattern means that an exclusion-based diagnosis is needed. A typical clinical presentation of canine atopic dermatitis is pruritus and erythema. The most frequent locations are the face, paws, ventral abdomen or inguinal regions, axillae, flexor surface of the tarsal joints, extensor surface of the carpal joints, pinnae and external ear canals. Chronic pruritus is characterized by secondary skin lesions, alopecia, crusting, and lichenification. Breed particularities such as lesion of the back of the Shar-Peis, Chow and West Highland White Terrier are subtle variation demonstrating that clinical signs can have lots of different appearance. Definitely, when one wants to diagnose CAD, the process must be structured and rigorous. The consultation will take time, the step-by-step process will be long, and the pet owner will have to be diligent and compliant. A diagnosis of CAD is based on a good medical history collection. The exclusion of the other differentials that fit with the clinical pattern, and the use of Favreau's criteria, and a food elimination challenge trial. Dog's medical history is very important and will give the vet an orientation whether the case is compatible with CAD. It also helps to figure which allergen type could be involved. The exclusion of the other dermatoses is also as crucial as there's no other test validated to diagnose CAD. The only way to rule out a cutaneous adverse food reaction is a food elimination and challenge trial. This step is indispensable and required before achieving a CAD diagnosis.